So with the direct effects of COVID, this is something that I wrote about on the blog, on my blog, which was a particular patient who was post-operative, um, and I was working on an evening shift. It was just myself looking after the ward with a senior who's covering both an intensive care unit, a cardiothoracic HDU unit, and the cardiothoracic ward as well. Now, the patient was on the cardiothoracic ward, and they started to develop um, a worsening respiratory picture. So worsening respiratory saturations, increasing oxygen requirements, increasing respiratory rate. They became increasingly breathless, and I was more and more worried about them. So I was asked to see them. I asked my senior to come and see them. And despite increasing oxygen requirements, they didn't really improve. Their oxygen saturations didn't improve. Now I became quite worried about this patient. So I went in there, I gave them nebulizers to help remove any secretions. We got chest x-rays. We started taking arterial blood gases to look at whether the patient's oxygenation levels had changed within their blood, and they were within they were in any particular type of respiratory failure. And despite being on the highest level of oxygen, so a 15-liter non-rebreather mask, this patient wasn't oxygenating particularly well after a few hours. So we had to call intensive care to come and see this patient. And it turned out that this patient had developed essentially acute respiratory distress syndrome. We took them to the intensive care unit. They were developing fevers, worsening respiratory distress, and actually it turns out that this patient had developed kind of coronavirus or some form of essentially COVID, some form of COVID infection following following surgery. Now that patient spent about two to 2.5 weeks in intensive care, and it was really distressing to see because that patient went off so quickly, and yeah, for me as a junior doctor, it was incredibly scary to see how quickly these patients can deteriorate.